Definitely. This is a fantastic question, and such interviews are only meaningful when we give messages like that to patients, and their decision making definitely uh, it enhances the decision. So, egg freezing is a very powerful tool. It is having a very special place in cases of endometriosis. Like you already said, Elizabeth, that if it is done early, so a younger egg any day would have lesser genetic abnormalities as compared to the older egg. And that is the main difference between the younger egg and the older egg. I would like to go back 2 steps on the physiology part for a bit. So every woman is born with a fixed set of eggs, unlike men who can form the de novo sperms. So sperms can be present in their body next month, in the coming 3 4 months, which were never present in their body a few months earlier, because they are de novo cells. So they are created from the precursors, but they are created de novo. We as women are born with the fixed set of eggs, and that decreases massively with age. So the central aspect is just to understand that as we age or not, lesser and the slowly the decrease happens after the age of 37 more steeply, and then after the age of 40 very steeply. After 43, even if the woman is pregnant with her own eggs, the percentage of the miscarriage is unfortunately 93%, and that is the effect of age. When it is compounded with the presence of endometriosis, the whole egg reserve and the egg quality, that means both the quantity and the quality, will be affected, and the decline of that curve we cannot predict for individual women, and hence an early egg freezing is very important, more important in women with endometriosis. In standard, um, in general cases where women are only freezing eggs for social reasons, uh, we promote that they should freeze by the age of around 30, 31, 32 for best results. And if the endometriosis is associated, I would say it would be late 20s or even mid 20s. A very good way to, so there is no direct indicator of ovarian reserve, but there are three indirect indicators of ovarian reserve. The first is age. The second is antral follicle count, which is the set of follicles which come out of the reserve for that particular month. And antral follicle count roughly remains the same, but every month it can be a little different. So it is seen best in the ultrasound on day 2 or 3 or 4 of the cycle. And the third indicator, which tells us about the ovarian reserve, well, how big is it, is a blood test called AMH, which is the anti-Mullerian hormone. So AMH has changed the way we practice, and it is not a very old discovery. This AMH has come into practice around 12 years back, 12 to 14 years back. So it's relatively a newer advance. AMH can be done on any day of the cycle, and it's a very easy way to indirectly indicate about the ovarian reserve. The only direct indicator of fertility is when the pregnancy is actually created. There is no other way. But when the AMH is low, that means this woman would definitely benefit from the egg freezing. Now you ask me, Elizabeth, how many? So because the younger eggs are going to have better outcomes, so lesser eggs are needed to. So just I'm telling you about the base on the basis of studies. Although we never know whether it doesn't apply to one particular woman, but I'm just telling you the aggregate of the larger studies, because these numbers would not apply to individual women necessarily, because everybody can have a very different quality of eggs. So generally, a younger woman will have better quality eggs. That means we need lesser eggs when a woman is younger to create one live birth in future. But as the woman advances, her egg quality deteriorates, and this decline can be compounded with the presence of by the presence of endometriosis. So, an older woman needs to freeze more number of eggs to guarantee the live birth, although nothing guarantees, but just to increase the chance of one live birth. So, there are studies which have told us about what numbers, uh, but this should be left on the doctor's decision based on the individual patient, I would say. There, but the repetition of the cycles is generally required if the egg freezing is done after 35 years of age. Um, and not every follicle has egg, and not every egg is mature, and we are only going to freeze the mature eggs. And that is why the need for repeat cycles is there. Generally, 3 cycles generally in a general population mean that there should be enough mature M2s, but the total number of M2s should be decided by the treating doctor for the individual woman. Roughly, we say that each egg has 5 to 6% chance to create a live birth in later age group if it is done up to the age of 35. But I would again emphasize that this number should be decided by the treating doctor who has enough experience in egg freezing. Egg freezing is a very advanced technique and art, because we are, just imagine, here we are freezing one cell. When we are freezing the embryo of the day 5 status, which is the blastocyst, has a few hundreds of eggs or hundreds of cells. And here we are talking about freezing one cell. So the freezing itself and the thawing, meaning the melting when we're using them, it itself is a lot of technology dependent process. We need to have a very good lab. The standard of the lab should be very good. These days we use vitrification. Unfortunately, I am aware that even in very good cities, some of the labs have still not completely shifted to vitrification. They still have been doing slow freezing, which is a good tested way of freezing, and a lot of eggs have been frozen like that, and they are still being used. But vitrification has been a very big this technique, and there are different ways, especially at the time of thawing. The eggs, when they are thawed, when they are used, is a very technology and skill dependent process. So this also affects, that how this set of eggs are being used to create live birth. But definitely the biggest power in a woman's hand is the number of eggs that she is frozen at the right age.